I'm Dr. Derek Cooney, filling in for Christian Knudsen as he is our primary host. He's on vacation, as are a lot of people, and being the last day of the academic calendar, this is an interesting time to have our talk, but we've got a great one today, and so I'm glad you guys joined us. And as usual, we were recording, and we'll be posting this on the EMS Medicine Live website, and so it'll be available for viewing later. Today it's Air Medical Services and Flight Physiology, and I'm going to introduce our speaker in just a moment. Just as a reminder, EMS Medicine's Live vision is to provide a community and academic EMS physician education source with information sharing and board preparation materials. Group involvement is essential to this project, and it's an opportunity to additionally meet and see our peers outside of usual conferences and meetings, and to also involve your unique experiences and skills, and also as a vehicle to educate ourselves and our fellows and residents. Course directors are Chris Knudsen, myself, and Brian Clemency. Just to review the ground rules for Zoom, during the presentation, everyone will be muted so that our primary speaker can be uninterrupted by background noise. You can chat questions to EMS Medicine Live or Knudsen, it's the same account this time, to be answered either during or at the end of the presentation. You can raise your hand virtually in the chat window, which is a feature of Zoom, and it's one of your buttons that you can click on. And again, we will be recording, and it will be available on the site and on the various accounts that EMS Medicine Live has set up. Again, we'll do the questions at the end for the most part. Unmute yourself if you need, when you ask a question, or no one will be able to hear you. It's like that classic conference call where it's silence, but someone's talking. And if there's any technical problems, go ahead and email Chris, and he can fix it for next time. Today's presenter is Christian Martin-Gill from the University of Pittsburgh. He's Assistant Professor of Emergency Medicine, Associate Director of EMS Fellowship, the Associate Medical Director of UPMC's Pre-Hospital Care, and Associate Medical Director of Stat Medivac. So we're very proud and happy to have him here today. And with that, I'm going to go ahead and cue up his presentation, and we'll get started.
All right. Fair enough. All right, so we got a few folks on. Actually, I didn't see that we had these folks, so good. Thanks for coming on, and let's get this done. So I was asked to share something, and actually the majority of this presentation, actually all of it, I condensed it to a 1-hour talk. But it was put together actually for NAMSP, and specifically with input from the Air Medicine Committee and the Education Committee from this initial push of trying to get some content that may be more challenging for some fellowships to be able to provide, because maybe they don't have a certain specialty EMS thing at their shop, or as closer ties to it. Or maybe even just to get some input from a different program and whatnot. So actually, in the initial push of this, we made an air medical presentation, a tactical EMS presentation. I got to spearhead this air medicine and flight physiology one. And so I've condensed it here, and I'll kind of talk quickly so we are done by 2 o'clock. And we'll just kind of run through some stuff. And the goals are to basically talk about air medicine as a whole, then talk specifically about some flight physiology and some clinical applications if you're an EMS physician that is going to be providing medical oversight or actually flying there. And there's some good work happening here. There's currently the NAMSP position statement on education of flight physicians and folks is currently being rewritten. And certainly there's interest in advancing the knowledge of air medicine among our community of EMS physicians. So Want to kind of talk a little bit about the background and the purpose of air medical transport. So generally, we're flying folks either from the scene or inter-facility transfers for critically ill or injured patients. Our goal is to transfer people in a safe, efficient, and expert manner, and recognize that the environment that we work in is particularly unpredictable. And that is very true for all of EMS, and particularly true when you are trying to do it at 2,000 feet up in the air with this big rotor ahead of, above you, and all of the other challenges that may happen with air medical transport. And an interesting historical view of this that I typically bring up when I talk about our medicine is just a history of where medical transport came from. And it really came from the Korean conflict and then the Vietnam War. And what you need to think about here is maybe most of us just watch this on TV. Some folks, could have lived this. But the concept of air medical transport in one time was actually a litter on the outside of a helicopter on either side that you strap your patient to, and then you transport them to where their care actually is. And so it became very important that you provided some kind of life-sustaining treatment on scene, and then you went through the period of transport with no care being delivered to the patient until you arrived at the next higher level of care in a battlefield setting. And so air medical transport, it started its roots on the rapid evacuation of patients without the delivery of much care en route. And in fact, that model has stayed through the military for a lot of years until more recently, where the military has moved more towards our civilian model of providing quite a lot of medical care during the transport phase. There's a development of trauma systems. This is how we developed trauma systems in the United States, recognizing that it was, potentially better to be shot in your chest in the middle of a battlefield somewhere else than it was on Main Street. And so trauma systems got developed and air medical programs got developed. And so early on, air medical programs were just for trauma patients, much like EMS was in the early days. And then it has expanded to really the management of all sorts of critical illnesses, emergency conditions, to include trauma and non-trauma conditions. And in modern days, we not only provide a very high level of care during that transport phase, but there also is a culture of safety, fact that we need to make this transport environment as safe as possible, that can have participation of strong medical direction from physician medical directors that are knowledgeable and very involved in those air medical programs, that there are quality assurance, quality improvement programs in place, and then we have robust evidence-based protocols and policies in place that we can utilize. To talk a little bit about different aircraft that you may come across. Typically, there are two versions: rotor aircraft and fixed-wing aircraft. Rotor aircraft, benefit of it is that you don't need an airport. You basically need a 100 by 100 foot landing zone. That has come up on some exams that I know of in different settings about what would make a safe landing zone for an air medical helicopter. And so 100 by 100 foot is typically a standard period of space, and certainly we want to make sure that that's free of wires and poles and trees and other hazards that might be present there. Another benefit is that you can do door-to-door transport, and this can be particularly important as we compare it with fixed-wing missions. So I recently had the opportunity to fly a patient from the University of Pittsburgh to Johns Hopkins Hospital, and this was a patient with pulmonary fibrosis that had a very high oxygen requirement. She actually had a 40-liter oximeter mask, and it was, if you think about that, 40 liters is 4 liters a minute is just a huge suck on oxygen, and we just don't carry that much oxygen on a helicopter. So we could do a fixed-wing mission with that, but then issue that would happen is that you have transitions of care. So if you're in a hospital, then you have to transition to an ambulance to take you to an airport, then transition into the airplane. From the airplane, you're going to the other airport where you're going to transition into another ambulance and ultimately transition onto a hospital bed at the receiving facility. And it turned out that as soon as you said the word move to this patient, she desaturated to 60%. I mean, it was amazing. I mean, you look at her and she would just plummet down very profoundly. And this was somebody that was, we were trying to avoid intubating specifically for evaluation for a lung transplant. And so, one benefit of rotor is that it's point to point. So we ended up actually completing the mission by rotor, placing her on BiPAP and doing some things to maximize oxygen use, and actually being able to put her on our stretcher directly in an aircraft and then landing at that facility as a door-to-door transport. And so now you can have one example of how it can become particularly useful to be able to have that door-to-door service. Aircraft typically fly about 120 miles an hour, so I like to think about it as 2 miles a minute when I do my calculations, and I think of how many miles away they are from the hospital. Typical service area that might come up on an exam question is 100 miles typical service area, but in terms of if you look at different aircraft and their range, as we'll discuss in a minute, the range may be better described as something like 350 to 450 miles. But a typical service area in terms of a ring around a base and whatnot is about 150 miles. They'll typically fly at lower altitudes, somewhere between 1,000 and 4,000 feet, and more commonly around the 2,000 to maybe 3,000 foot range. And we compare this with fixed-wing aircraft where you need an airport to land to and from. Certainly they fly much faster, and this depends on whether it's a propeller or a jet airplane, and they travel at higher altitudes. So when we're talking about flight physiology and a lot of the things that happen up in altitude, we're largely talking about fixed-wing transports in the things that can happen when you have a cabin pressure of 6,000 to 8,000 feet, which equilibrates to, that is typical when you have an aircraft flying anywhere between 20 and 40,000 feet. So in terms of rotor wing engine or rotor wing aircraft, we have single engine rotor aircraft. They're less expensive to operate. You can imagine that the fuel costs burning one engine versus two engine is nearly half the cost. It can unfortunately be associated with some reduced safety margins. In the safety piece of it, when you look at aircraft crashes that have involved single-engine rotors that was potentially attributable to that, it happens in one of two environments. One is that you have an engine failure. Unfortunately, an engine failure in a single-engine aircraft can be particularly problematic. You can try to auto-rotate to land on the ground, but you certainly have much less room for any kind of maneuvering and control than when you have another engine still working. And the other issue that can occur is when you are down near the ground and are getting ground effect, and you can, if you don't have enough power managing that tail rotor and the propeller and the tail rotor combination, then you can have what's called a loss of tail rotor effect, and you can actually go into a spin that causes the tail to crash into something nearby, like a tower at a helipad. And so those have been some concerns that have been raised about single-engine aircraft, though many of them are operated in quite a number of sites across the country. There's also typically no instrument flight rules capabilities to be able to fly in inclement weather. But some advantages are that it can fly at higher altitudes, typically in very hot ambient temperatures, and so there are some benefits to these types of aircraft. Then we have twin-engine aircraft. These folks can have some additional power that's available that is particularly important for landing and takeoff operations. They have a single engine, which is particularly useful if one malfunctions in flight. And there are a number of other capabilities that are typically available on twin-engine rotors that are not available on single-engine rotors, like instrument flight rules capabilities, some newer models having de-icing capabilities, terrain and collision avoidance systems, and whatnot. But certainly they're much more expensive to operate. There are other, even larger rotor wing aircraft that are typically thought of as having multi-missions. So, for example, the Maryland State Police primarily operates the Dolphin, which is also known as the EC-155 from Eurocopter. It's a large aircraft. Here you see a model operated by the Coast Guard, and you can certainly have other capabilities of that, whether you're using it for dual missions of police and EMS, as well as for fire, for search and rescue, and for other capabilities. Fixed-wing medium-range aircraft, or things like the King Air, the Pilatus, that typically fly about 200 to 300 miles an hour. They're certainly more inexpensive to operate than the jets. It can be configured for all-weather flight. And then our longer range aircraft, like the Lears, have much greater speed. They can go intercontinental and can do international missions and things like that. But of course, the most expensive to operate out of all the aircraft we've discussed. Configuration of crews really varies across the United States, and probably varies even more when you look internationally. Typically, it's at least a two-person crew. That crew is either two nurses, a nurse and a paramedic, or a nurse and a physician. In some cases, a respiratory therapist will replace one of those providers. And then you have some other specialty teams where you may have a like an LVAD technologist, again, the respiratory therapist that may replace one of the crew members. You may have folks that make up part of a pediatric team, like a pediatric intensivist or a neonatologist that can replace other folks. So often for the specialty teams, you'll end up with at least 3 providers, but the most common configuration across at least the United States is a nurse paramedic, and in Europe, more commonly a physician paramedic or physician nurse configuration. Specialty teams are varied and are widely utilized. Pediatric and neonatal teams are probably the most common. There can be high-risk OB teams that come to a facility when it is deemed unsafe to transport a mother in labor, or when you have a newborn. Possibly those OB teams may be combined with a neonatal team to go directly to that facility. LVADs and ECMOs, as well as balloon pumps, have been increasingly utilized as cardiac assist devices that are placed in community settings. The balloon pumps are actually very commonly transported by air medical crews, sometimes with the use of a technologist that is what we call an engineer that specializes in using that. For some other transport teams, they're actually trained in utilizing that equipment. For example, I use our own shop at Stat Medevac. We have a 17-base helicopter system across Pennsylvania, Ohio, and Maryland. And all of our crews are trained in using balloon pumps, and we do those transports commonly, and that is also the model at a variety of other places. Acutely placed left ventricular assist devices are certainly the use of ECMO is typically transported using an engineer. And then transplant teams can also be utilized as part of an air medical program to retrieve organs and or patients. So the capabilities of nurses or paramedics in this environment actually varies by state, and it varies by state in a very interesting way, to the point that you may be in one state, and in that state a nurse can push a paralytic but a paramedic cannot, and suddenly you fly over a border where the paramedic can push a paralytic but the nurse cannot. And in fact, we have one of those borders in this part of the U.S., which is kind of an interesting situation. Typically, the regulations are set up based on wherever an air medical program is based out of. So, for example, we have a multi-state air medical program, but we're based in Pittsburgh, Pennsylvania. So our protocols are funneled from within this region through our regional EMS council, then to the Pennsylvania Department of Health, and then they're utilized regardless of what what area they're involved in. But in terms of licensing, in terms of providers having to be licensed in those states and the air medical service having to be licensed in those states, the regulations vary. And so, for example, we have to hold licenses in Maryland and in Washington, D.C. and in a number of other places to be able to operate in those environments. So this is something that, as an EMS medical director, you would want to review with your operational staff and make sure that everything is shipshape. So potential indications for medical transport from a scene include cases of time-dependent conditions and or the need for critical care interventions. In this distinction, these two questions that come to play when you have to make a decision about whether to use air medical critical care transport are really two distinct and different questions. Do you need to use the air medicine capabilities for a time savings, and or do you need to use the medical crew available in an air medical transport for the critical care interventions that they can provide? That may be the availability to do rapid sequence induction if the patient deteriorates or when you arrive on the scene or in a facility. That may be the capability of blood product administration that's not commonly carried on the ground, but may be on an air medical asset. That may be, a variety of other medications, interventions that may be delivered by a critical care medical service that is not otherwise available. And it turns out that these assets have to be available in a regional setting. It would be nice for us to have a critical care transport group available at every single hospital, even they're not available for every couple hospitals. So these are typically regional assets. And so, as what we mentioned to referring physicians is to have those two considerations in mind. Determine if you need a critical care transport, then see how that might be available. You may have that available by ground, or you may only have that available by air. And then determine if you need the air simply because you have a time-dependent condition, even if interventions aren't necessarily being immediately performed. Other reasons that air medical transport is utilized is because of a lack or limited availability of ground resources. So in some cases, you may be about an hour, hour and a half away from a hospital. You need to get the patient to that hospital setting. Let's say that somebody needs to go to a tertiary care center for trauma services, but you're an hour and a half away. You serve a smaller area with a small community hospital that is not capable of transporting a trauma patient. Let's say that you have somebody that may be okay sit in an ambulance for an hour and 15 or an hour and 30 minutes. But unfortunately, you're the only ALS provider in your region. And if you drive that patient that hour and 15, hour and 30 minutes, that time on scene, that time at the facility, that time coming back, your service area will be without ALS services for 3 hours, for example. And so an air medical asset may need to come to pick up that patient, transport them to the trauma center, purely because there are not enough resources to do a long distance ground transport. In some cases, there may be traffic or other road conditions that may make a shorter transport more important. So if you have a patient going from one hospital to another hospital, but they're only separated by a bridge or a tunnel, and suddenly that's under construction and backed up, it may take you an hour, hour and a half to get a short distance, and sometimes air transport is necessary in those conditions. And so we've covered essentially some of the needs as well for a medical transport. And additionally here, there may be some specialty services that are needed that would not otherwise be available on a ground units, like the specialty teams and other things. So some contraindications to transport have to do with safety. So if you have unsafe weather, that would be the first reason not to transport somebody by air. Certainly there may be some size restrictions about what size patients can be moved in different aircraft. I know we operate the Eurocopter EC-135 and EC-145. We have transported a 700 kilogram plus patient in an EC-135 and an 1100 kilogram patient in an EC-145. So often this becomes a matter of girth and size more than it does a matter of weight, which is just a factor of how much fuel you're carrying on, and certainly the capabilities of the aircraft. These are a twin engine aircraft with a lot of lift power. If you work in an aeromedical program, you should know what restrictions you have for size, girth to actually fit them in to that space. In some cases, height, particularly for those that are side loading aircraft. You actually may have some restrictions or limitations about how you load the patient in that environment. And so those are all safety and operational considerations. Some medical considerations is, we will typically say that the two groups of patients that are not stable for aeromedical transport are those that don't have an airway and those with active compressions. So those are most commonly the ones that we may arrive to a scene and we say, nope, we're going to go by ground to the closest facility because for some reason we're not able to establish an airway, which is quite rare, or more commonly that somebody has a cardiac arrest and we don't achieve ROSC, somebody has active compressions, and to provide active compressions in a helicopter is challenging, and one of the reasons where we may just go to the closest facility by the fastest means possible, and often that may be by ground. Certainly newer devices like mechanical CPR devices have changed the game a little bit there, particularly when you may consider transporting somebody for eCPR, being able to put somebody on ECMO and doing other advanced capabilities. Certainly these are things that are still rarely but increasingly being utilized. And so there may be some cases where you may want to do CPR and go to another center. For example, another case that may come up is when you have somebody who's shot in the chest or has a significant traumatic wound where unless you get that person to a trauma center where they're going to have capabilities for example, maybe a thoracotomy or other things, then there really is not going to be a chance of survival. And so that may be another rare occurrence where you may take somebody who's borderline or even really we're just starting going into cardiac arrest and try to do a longer transport in a short period of time by getting the patient into an aircraft. And finally, we mentioned patients in active labor. This can be particularly challenging, certainly when you're the medical director and you get a consultation. Say I have a woman, she's in active labor, she's 5 centimeters, she's having contractions every 5 minutes, she's having no active urge to push, but really the contractions have been getting a little bit faster. And is it safe to transport the patient? And there really are no guidelines to say, this is exactly when it's safe and when it's not safe. There are certainly some situations where somebody is, minimally dilated and, having wide apart contractions where I think it's black and white, it's safe to transport. There's some other cases where, boy, that hospital really wants to get that patient out of that small community setting where maybe there is an OB or maybe this is a high-risk delivery, maybe it's a preterm labor. And we really need to want to get that person to the Mecca where they're going to have all those neonatal, maternal fetal medicine capabilities, and really try to push you out the door. And it can become a challenge to decide if somebody is safe for transport. The only guidance that I have is, sometimes experience and seeing where your distances are, and just have a really good story and history from what's going on from the folks that you have there on scene, as well as involving folks like maternal fetal medicine at the receiving facility to come up with a decision and determine if it's likely that this person's going to deliver in the next 30 or 60 minutes. Some limitations of air transport is that aircraft by their nature can be crowded, claustrophobic, noisy. There's a lot of vibrations, and it's interesting, the vibration piece of it actually wears people down a lot. So when you look at causes of fatigue for aeromedical transport crews as well as for patients themselves, the vibrations have actually been cited as being a substantial kind of wear on flight crews. So if you have an aeromedical crew that maybe has done 2 or 3 back-to-back missions, they were long transports, so they were actually in the air for maybe an hour at a time, and so now they've just had maybe 6 hours of flight time in a short period of time. If you've done that, you will feel beat. I mean, you will feel like you just you just worked 2 days, and certainly that is not just the vibrations, but the fact that you're doing a lot of activity in a short period of time, probably lifting patients on in and out of the aircraft and doing a number of other things, but that's one of the things to consider. Temperature can also be a particular concern. This has come up frequently in potential answers to questions of things that you may want to mitigate for patients. So as you go up to altitude, temperatures do get colder. We'll review that in some flight physiology points, but this is something that you need to be mindful of and make sure the patient's warm. And conversely, in the summer, you may or may not have a great air conditioning system in the aircraft. And if you don't, then you can really get into some extremes of heat depending on where you're located. And that is also something that needs to be measured. And CAMES, which is the accreditation group for air medical transport services, or the one that is most utilized by air medical services, actually requires the assessment and documentation of ambient temperatures during transport and a process to mitigate and to review cases where there is an extreme of temperature, either too cold or too hot for the patient. Some points on scene rendezvous and helistops. So it's common for ground EMS to rendezvous with an aircraft in a variety of scene locations. We mentioned how those locations should have a space of at least 100 by 100 feet and be free of dangers around that environment. But sometimes they'll say, hey, where should we set up this LZ? Should we use that parking lot? Should we use that ball field? Oh, wait a minute. There's a helipad right there from the hospital that we're not going to go to because they don't have a trauma service there. But boy, wouldn't it be convenient if we could just land the helicopter right on that H? And so helicopters do this very commonly. It is okay to rendezvous at a helipad. The kind of crude term for that is a helistop. And in some cases, the hospitals will have agreement with the EMS agencies to be able to use that helipad as just a rendezvous point. And an important thing that has come up in the past is to say, well, wait a minute, I just stepped onto hospital property. That helipad is owned by the hospital. It is part of that hospital grounds. Aren't I committing an EMTALA violation because I have quote arrived at the hospital? And it turns out that that is not the case. As long as the patient and EMS crew are not seeking care at that facility, then the EMTALA obligation has not been kind of enacted because they're literally just using that space to rendezvous with a helicopter and have not sought care at that facility. So there is no EMTALA obligation. Now, on the other hand, if suddenly medical providers from the hospital come out and begin assessing the patient, well, whether they ask for it or not, the hospital arrives to the patient. And in those cases, you need to be very mindful about making sure that you secure a hospital-to-hospital transfer with an accepting physician, availability of beds, transfer documentation, ensuring stability of the patient, and all of those things that are key to EMTALA. But as long as it's physically just a pad being utilized, then that's done and not an issue. Risks and costs I'll mention just briefly here so we can get to some flight physiology things. Something that's been on a lot of minds, sky-high bills. It's on the papers periodically. Transport cost charges range anywhere between $10,000 or $50,000. Is it cost-effective? Is it reasonable? Certainly, there's some programs that have sky-high bills. Other programs that are able to maintain costs and charges down. There have been a couple of papers published as recently as 2012 in JAMA that have looked at the quality-adjusted life year saved through air medical transport, and it's about $15,000. So most medical interventions that are less costly than $50,000 per quality is typically deemed to be cost-effective. The argument that I could get into, or somebody could get into with this, is how are these patients selected, and certainly the cost-effectiveness is more for those who are critically ill and less for those who are not ill. That is the truth for any service, whether it's that you're admitting somebody to an ICU or you're providing any other care. If they're going to do okay anyway, then that's just a cost that was unnecessary. So it continues to be important that we triage patients appropriately and utilize this resource in an appropriate manner. Other issues is whether it's too risky to fly somebody. Helicopters crash. I saw one on TV. I'm worried about putting somebody in a helicopter. I'm going to put them in an ambulance instead. And so, what I call this to be a little bit of the commercial airline phenomenon, right? So you remember at some points with my family saying, "Oh my goodness," actually this is probably more the case maybe 20, 30 years ago, where you say, "Oh, an aircraft, a commercial aircraft crashed. Oh, flying on commercial aircraft is unsafe. I don't want to get on an airplane," and realize that it's just such a rare occurrence compared to all of the transports that exist. However, we have had a rash of helicopter crashes that have occurred, and so let's compare this to the fatal accident rate for general aviation, which is about 1.1 per 100,000 flight hours, and realize that it's about the same for helicopter EMS aircraft. So it's the same thing as general aviation in terms of risk of being up in the air. But let's compare it with ground transport, because you can really Google ambulance crash and find the latest ones from a number of, from anywhere. Here in Pennsylvania, we have an average 1 ambulance crash per day in the state of Pennsylvania. And that just doesn't make the news all that often unless it happens in your neck of the woods. So what's the risk to the patient for ground EMS? If you look at the published literature, you come out with about 0.02 deaths per 100,000 miles. And this is recognizing that there's a gross underreporting of injuries and fatalities on ambulances because there's no mandated reporting. So even accepting the fact that you have underreporting of fatalities and injuries on ambulances, that's what the published death rate per 100,000 miles would be if you calculate it. And for aeromedical services, you essentially come out with the same thing. When you talk about per distance traveled, it's about 0.02 deaths per 100,000 miles. And in this case, all deaths that occur from aeromedical services are required or mandated to be reported. So a little bit more accurate. But even if we take the numbers to be accurate for both groups, you see that just because we're putting somebody in an ambulance doesn't mean it's all that much safer. So take that from an aeromedical guy, but certainly I think that folks need to look at the numbers when they think about that risk. And there are many ways to mitigate the transport. You can use instrument flight rule capabilities, which allows you to fly through the clouds and with limited visibility, ability to have night vision goggles, GPS approaches, having the twin engines, as I mentioned, having information systems, including traffic collision avoidance systems and enhanced ground proximity warning systems. This is basically in your helmet, suddenly you say, aircraft, aircraft, aircraft. And it tells you that half a mile out you have an aircraft and you need to know where it is and make sure that it's not on your flight path or they're in yours. So moving on to some flight physiology pieces, I'm just going to give you some of the nuts and bolts of what you need. Again, this is prime fodder for anybody who might want to sit down for an EMS-related exam in the near future of a few months from now. So recognize that our atmosphere is up to 70,000 feet. Nitrogen makes up about 70% of air, and the other majority is oxygen, which is roughly 21%, with a little bit of everything else mixed in. And this is what happens when you go up in altitude. Your barometric pressure decreases, the partial pressure of oxygen decreases, gases expand, and temperature falls. And here, just as a comparison, how much does it fall? So for about every couple thousand feet, you drop a degree Celsius. So not a huge difference in and of itself, but certainly somewhat of a measurable difference there. So we're going to talk a little bit about some gas laws. Again, this is prime fodder that folks like to look at, and in fact are related to the medical conditions you need to be thinking about and concerned about when you do aeromedical transport. We'll discuss specifically about how that is more important for those that are doing fixed wing missions where the cabin pressure is certainly much higher than on a helicopter transport. And so that's something to be very cognizant of. What is the flying altitude that you will be at physiologically in terms of actually potentially having to make some calculations to be ready for that mission. So Boyle's law has to do with expansion. Specifically, it's the volume of gas being inversely proportional to pressure when temperature remains constant. In fact, as you go up into altitude, as temperature decreases, in theory, volume should decrease as well, but this proportional change is actually much greater than the impact of temperature as you go up, as you decrease pressure. So even if you don't maintain temperature constant, for that 1 degree Celsius difference that I told you about, that happens with about every 2,000 feet, still the volume expansion wins. Boyle's law beats temperature changes. So be mindful of that. And this is important for any gas in an enclosed space that will expand as you go up to higher altitude. Now, the body is typically adaptable to about 10,000 feet. 10,000 feet is pushing it. 8,000 feet is the typical, between 6,000 and 8,000 feet is the typical cabin pressure of a commercial aircraft. And really at about 8,000 feet, you're starting to push it with certain patients that have chronic conditions in terms of oxygen, and also not being related to this law, but even when you have some expansion of folks that maybe are post-op from malaparottomy and still have some gas in the air, or even may have some flatus and whatnot, you do see some expansion of gas that may cause some abdominal and intestinal pain, that may cause expansion of some other issues. For example, endotracheal tubes. Well, these are filled with air. The pilot, cuff is filled with air. And if you're flying at altitude, you may need to be concerned about that expanding, that rupturing, that causing tracheal damage, causing an air leak and difficulty with ventilation. So a couple things can be done to mitigate it. One is to actually carry a manometer where you test the pressure and maintain it at a certain amount once as you are reaching altitude. Another way to do it is to inflate the cuff with air, and then there's no change in volume as you go up into air. Also applies to hyperbaric chambers. So if you are placing somebody in a hyperbaric chamber and you're changing the functional pressure of them, typically in a hyperbaric chamber you will put them under much greater pressure. Well, then the volume will decrease in size, and so now you may need to have a mechanism to mitigate that. And so commonly when you have an intubated patient going into a hyperbaric chamber, you'll have to make sure that that cuff is inflated with water and not with air, or it'll just cause an air leak because it's not appropriately inflated at the higher pressure. Intravenous strips are important to be mindful of. As air expands, if it's an enclosed space, your flow can increase. So this makes it particularly important to have intravenous strips on pumps that are can regulate and are not affected by that flow difference. Splints, like vacuum splints, another thing you need to be mindful of, may suddenly become much tighter or deflate depending on whether you're ascending or descending. Transport ventilators must be prepared to be utilized in flight and must be rated to be able to adjust for changes in ambient pressure. Then we have patients that actually have physiological, air pockets. And so here we see somebody with a pneumothorax. So, what's going to happen when somebody with a pneumothorax during transport in a helicopter? Well, it's kind of interesting. Certainly going up to great altitude, you're going to have expansion of that pneumothorax. A question that comes up then is it just unsafe to put a patient with any pneumothorax into any kind of air medical vehicle? And so then you have to ask yourself, how much does the volume of a pneumothorax, or really any pocket of air, expand as you go up in altitude? And you can actually calculate this. So it turns out that for a flight level about 6,000 feet, you actually increase the volume of that space by about 25%. It becomes between 30 and 33%, to remind myself, when you get up to 8,000 feet, which is common for commercial aircraft. So yes, if you have a pneumothorax, you're about to put that patient in a commercial aircraft, you need to think twice, because you will have an expansion of a third the size of that pneumothorax as they go up. And certainly, there are recommendations for when not to put people with recent pneumothoraces on commercial aircraft. typically at least 1 to 2 weeks after radiographic resolution of the pneumothorax. But in some cases, you may be on an island. You may need to fly somebody to get to another medical center, and they have a pneumothorax, and there's nothing you can do about it, but maybe dart the chest. And so you need to be mindful that that pneumothorax could expand, and what are you going to do? Certainly, it would make more sense to place a chest tube in before you put that person in aircraft. On the other hand, most helicopters either fly below 2,000 feet or can fly below 2,000 feet above sea level. And so in those situations, they will have a less than 5% increase. And if you're not flying near sea level, so if you're already on a mountain, then you just need to figure out how much above your current altitude you're going to be flying. So, if you actually need to go above a ridge where you're going to be flying up higher at, maybe 5,000 or 6,000 feet, well, suddenly you're going to get into the same issue that you would get into doing a fixed wing. So typically for most helicopter transports that are going relatively low to the ground, so somewhere between 1,000 and 2,000 feet, pneumothorax doesn't really expand all that much, and the air medical piece of it doesn't actually become that important physiologically, but certainly going up at higher altitudes, it's something that you have to calculate and be ready to address. Dalton's law talks about partial pressures, and that the total pressure of mixture of gases is equal to sum of the partial pressures of each gas in that mixture. So what this basically means is that as altitude increases, the atmospheric pressure decreases, so the total pressure decreases, and then the total content of oxygen essentially decreases as you go up into air. So even though the fraction of oxygen, so the percent of oxygen is still 21%, up at altitude, the total content of oxygen in the air has decreased. And how much does that happen? So if we take, for example, at, you can see here at sea level 5 and 10,000 feet, you have a third decrease in the PaO2 of patients. So it certainly can worsen hypoxia. Now, this is commonly encountered when you have people with chronic lung conditions that may go on a commercial aircraft. Their oxygen saturation may be 98% at sea level, it'd be 87% at 10,000 feet. Certainly if there's a depressurization or something, we'll all get hypoxic in the air. So how can we increase it? We can provide more oxygen, we can increase the atmospheric pressure and descend. So this is a limited problem again for helicopters that don't fly all that high. It's more of a problem for fixed wing aircraft that do go high, and so supplemental oxygen use is often used for critically ill patients. Some advantages of pressurized cabins related to the laws that we have just talked about are that you can limit the increase in size of gastrointestinal trapped gas. It can help with temperature, humidity, ventilation. You don't need to worry about additional oxygen and the fatigue and discomfort, things like that. Certainly it adds structural weight and maintenance and other issues. So Dalton's law in action, their COPD level, oxygen saturation was 95% on a commercial aircraft. You go up to 8,000 feet, which is common, and now at 86%, that person's short of breath. Solution is that on many commercial aircraft, they provide the capability to set up a portable oxygen concentrator. This is very different from just showing up at the gate and saying, hey, I heard you have oxygen on the airplane. I'm just going to use that. That's not going to get you very far. In fact, it will get you off the airplane. Something like a portable oxygen concentrator has to be set up a few days in advance. So, warn your loved ones and your patients. All right, Henry's law has to do with dissolving gases in a solution, being proportional to the pressure over the gas in the solution. So this is what happens when you open up a Coke can. When the pressure suddenly decreases because it equilibrates from the environment, then gas tries to come up out of solution. And it's clinically important for decompression sickness where nitrogen has made it into the body, for example, during scuba diving. And as you go up into altitude, then there is some of that kind of fizzling out of solution. So let's take the example of your scuba diver that, with scuba diving had no problems, then suddenly has a traumatic injury, has to be flown off from one island to another island. And as you get them into altitude, that suddenly they start experiencing the bends. And typically this is painful joints, can be attributed with neurologic symptoms and other issues. So for these folks, we want to descend best we can and then actually typically we'll use a hyperbaric chamber to get them back to where they were before. Typically, for a single non-decompression dive, you want a minimum of 12 hours before flying, and for multiple dives or any stages of ascent, at least 24 hours. Graham's law has to do with gases diffusing from higher or lower concentrations. This is a little bit less touched on flight physiology, but it does have to do with the use of heliox. That's why it becomes useful to utilize a combination of gases where the oxygen will diffuse more easily because of the density of helium versus oxygen. Charles' law has to do with when pressure is constant, that the volume of a gas is proportional to its temperature, and gases expand as they're heated, like in a like they would in a pressure cooker. If could be related to an explosion, the gases will suddenly want to expand. And Gay-Lussac's law is a little bit related to that. Pressure and temperature are directly related when volume is constant. So the classic example of this is if you talk to, you finish your shift and you transition over the aircraft to the night team, and it's 5 p.m. It's been a hot day. You look at the oxygen cylinder. Oh, that looks at about I don't know 1900 psi. It's full. That's good. When the crew comes to check the aircraft the next morning, they realize that you're down maybe at 1800 psi, and you might say, that's 100 psi difference. Is there a leak in the tank? And the difference is that no, the temperature has just decreased by 10, 20, 10, 15 degrees, and actually the pressure will therefore decrease directly with that as well. So there we go, aeromedical transport and flight physiology. Some of the things that we've talked about is that aeromedical transport requires substantial attention to operation, to understanding the environment, to understanding the unique challenges and issues that have to do not just with the operations, but also the impacts of altitude on the patient, the impacts of the whole environment on both patient and providers, and how you manage those situations and mitigate the negative impacts of it. Certainly we, as clinicians that work in the pre-hospital setting, need to be familiar with aircraft limitations, what their aircraft and operating characteristics are, when it's safe to use them, and when we would use different assets. The altitude physiology is prime fodder for questions. So next time you're cramming for that board exam, make sure that you review some gas laws for yourself and be familiar with how to apply that to some concrete examples. And finally, I'd be remiss if I didn't mention crew resource management. So it's an essential component to how you mitigate all of these issues that can happen, making sure that the flight crews and the pilots are well in sync, that people are working in an environment where they feel comfortable with saying no to a flight, where they have principles like it takes 3 to go and 1 to say no, to be able to make sure that the operations of an aircraft are safe, and then you mitigate other issues that may come across. And that is all. So we'll open it up for any questions.
So Chris, this is Derek. Just out of curiosity, do you guys replace the air with still water in your endotracheal tubes for rotor wing, or is just exclusively for fixed wing, or do you guys simply monitor the pressures?
Yeah, we do not. We actually don't change them at all. And that's because we'll typically fly about 2,000 feet, and just going through those equations, that's less than a 5% difference in volume. So we don't think that that's physiologically impactful for our transport differences or transport distances, and just based on the amount of air and whatnot that we're currently utilizing. I don't think that most people's kind of sensitivity of how much air you're putting into that balloon is even within 5% of when we did it the last time. So it probably doesn't matter. But for sure, and we do fixed wing missions. Whenever we do a fixed wing mission, that is one of those considerations. And so we'll typically either using a manometer or potentially filling it with water. But more commonly, I think what's utilized in the fixed wing setting is actually the use of a manometer.
With no other questions, it must be that everyone's an air medical expert. Good job.
All right. Well, we accomplished the mission then. Very good. Well, I appreciate everybody coming on today, and hopefully it was helpful for some folks and some other folks to catch this online and be helpful to them as well.
So just as a reminder, there's a Facebook page where people can make comments and take a look. The Upstate Emergency Medicine website has direct links to the webinars, but we also have a YouTube channel, which actually folks could subscribe to directly if they're into YouTube or have a YouTube app. They may be able to see it directly that way. Our next EMS Medicine Live is again on a Tuesday at 1 p.m. and it'll be July 28th. So we're hoping to see all you guys come back for that, and hopefully we'll get all the fellows popping in on that one as well. So thanks very much for attending EMS Medicine Live, and we'll see you next time.